His blood pressure was dangerously high no matter what he did to try to lower it. On today's All Things Heart, see how his doctors here finally discovered this difficult to diagnose condition. Good morning, I'm Alexis Del Cid. Welcome back to All Things Heart. Alex Lovely was doing everything he could to lower his blood pressure. He was eating right, he was exercising, he was taking his medications regularly. But it would turn out there was something else happening inside of him that was completely out of his control.
Never entered an interview like that before.
We meet Alex Lovely at the Kansas City school where he works. It's after hours and just a few hours before the annual fall dance.
Yes, welcome to the Under the Sea fall dance.
The 41-year-old father of three is the facilities manager here, a job he loves.
Every day is a new day. It's great. The kids are great.
And life is great now for Alex, but the years leading up to this point have been pretty brutal health-wise.
I've had L3, L4 back surgery. I got a MRSA infection, which resulted in another surgery to clear out the MRSA. Hernia surgery. I had viral meningitis that I was hospitalized twice for, and I was hospitalized this summer for another back injury.
And his most recent diagnosis took decades to figure out.
Had you ever heard of hyperaldosteronism before?
No.
Hyperaldosteronism, when the adrenal glands produce too much of the hormone aldosterone. Aldosterone helps regulate blood pressure. If left untreated, it greatly increases your risk of having a heart attack or stroke. For decades, Alex had no idea he had it.
In my late teens, early 20s, I had medically significant blood pressure, so it was 210 over 180.
In two instances, it manifested as chest pain so severe that he was rushed to the nearest emergency department.
I believe I was on 9 different medications to keep my blood pressure lower. At the same time, 7 to 9, and most of those were maxed out on their dosage level.
After establishing care at the University of Kansas Health System, it was Alex's general practitioner, Dr. Brandon Comfort, who referred him for an intricate test to determine if Alex had hyperaldosteronism.
They took a blood sample from the vein leaving the adrenal gland. The science to do that is like threading a hair, a needle the size of a hair, into a vein the size of a coffee stirrer or smaller. They were quite surprised that it was bilateral.
Alex was one of the first patients at the health system to undergo the test. The diagnosis has been life-altering.
KU has been such a blessing to myself and to my family because of the multi-variant expertise. KU is a teaching research hospital. It's cutting edge. I think it's a real testament to Dr. Comfort and the care team that's come around her that they took the time to do the work to figure it out.
Alex joins us in studio today. Thank you for being here. And he brought his son, who's in the control room. It was really nice to meet your little boy, one of your kids, along with his internal medicine physician, Dr. Brandon Comfort, and cardiologist, Dr. Shannon Hughes-Thompson, joins us online from Olathe. First of all, Alex, how are you feeling today?
Feeling great.
Yeah. And one of the huge changes was your medication list.
Yes, yeah, as I said in the clip there, I was on 7 to 9 medications. I'm now down, I believe, to 4 blood pressure medications, 4 or 5. But those are also lower doses, so we've really been able to dial in what would be needed to keep me at a healthy blood pressure level.
And what is, if you don't mind me asking, do you know what your blood pressure is now?
Not this minute, yeah, well, with medication, yeah, this minute it might be higher. With medication, it's right around 145 over 65.
Okay.
Or wait, no, that's a little high. 125 over 65.
Okay.
Yeah.
And so, Dr. Comfort, can you explain the testing process? I loved how Alex explained it. Is that basically it?
Yeah, he explained it better than I could. And, you know, first of all, thank you, Alex, for coming on. We always respect and admire our patients who are willing to share their stories, and so we appreciate that and love that you're doing so well. Yeah, the initial testing for hyperaldosteronism is really quite simple. It's just a simple blood test, and so we can, you know, I think in Alex's case and any of our patients who we're testing this for, we're going to send them down to the lab and just check aldosterone level in the blood system. We can compare that, and that can give us a good sense of whether or not they're hyperaldosterone or not. And then the next question is always, is this bilateral kind of hyperactivity of the adrenal glands, or is there a nodule or something like that sitting on the adrenal glands that's producing excess aldosterone hormone? And so in those patients, you know, we had a CT scan previously on Alex actually that showed that he had a nodule on his adrenal gland, his right adrenal gland, which raised our level of suspicion that perhaps this is a unilateral disease process where that nodule on that adrenal gland was spitting out too much hormone, and that's why we sent him through that extra testing. And the reason we do that, Alexis, is because it changes our treatment approach. So bilateral disease is going to be medical therapy only. Okay. Surgery is not going to help us in that case. But if it's a unilateral process, or there's a node on there, our surgeons can go in there and take that out, and that can be curative in a lot of cases. And so it's really important for us to try to differentiate that. And
but in Alex's case, it was on both sides.
It was on both sides, okay. Yeah. So we sent him through, and that procedure really is, you know, just to give a shout out to our interventional radiologists. They're the ones who do this. They thread a catheter through the femoral vein, which is down in our groin, and you know, it's miraculous to me how they get there, but they somehow can thread that up and get to the adrenal vein. It's really amazing. So big shout out to our interventional radiologists who do this test for us, and then they can actually test that aldosterone right out of that adrenal gland.
I want to bring in our cardiologist, Dr. Shannon Hughes-Thompson. Now, Dr. Hughes-Thompson, you don't treat Alex, but you do treat plenty of patients who have high blood pressure as a cardiologist. How often do you see a patient that has hyperaldosteronism?
Yeah, so you have to understand that hypertension overall is rarely just a primary etiology. Somebody who has long-standing hypertension, usually it becomes pretty multifactorial, even if it started out with just a singular cause. So as far as hyperaldosteronism, that's very frequent. Gosh, by the time they get to me, they probably have a certain component of resistant hypertension, and usually your aldosterone levels are abnormal, and so you treat that medically, or a lot of times with or without the test. I'll use medications that kind of go after that component. As far as primary hyperaldosteronism, that's more 15–20%, and it's really important. You start out with the blood tests. You potentially can do some urine and really more prolonged lab tests. The imaging can help. You have to understand these primary tumors or secreting cells. They're so small. And again, the reason you do a surgery if it's unilateral, you need your adrenal glands. They're critical parts of your endocrine system, and hormones, and if you take out your adrenal glands, you collapse. So the answer is that it's a major component, and a lot of it's secondary. As far as pure primary, that's pretty rare. But as far as a component to hypertension, it's very common.
His blood pressure, Dr. Hughes-Thompson, at one point was 210/180. What's considered a healthy blood pressure?
So we know that normal blood pressure is the systolic pressure, usually between 90 and 120. We always talk about the top end, but we don't, and it's resting. I think you have to really understand it's a purely resting blood pressure. Your systolic the top number should be under 120 and probably above 90. And the diastolic number, the lower number, should be usually between 60 and 80. So if you're in a pure resting state, for all of us right now, just because we're engaged in a conversation, if you checked our blood pressure, it shouldn't be obviously much more than that, but if it was slightly higher, you'd want us to go to a more pure resting state before you truly said, okay, your blood pressure is normal or not.
And then can you explain again how high aldosterone levels can affect the heart specifically?
Yeah, so just extra stress. So you're actually just, our hearts beat 70,000 times per day. And so if you're causing the heart and the vascular system to be hyperdrive, beat by beat, that's extra force and power. I mean, I think about it like it's a pounding fist. If you pound on something extra 70,000 times per day over the course of a lifetime, 50 years, you're going to cause dysregulation and dysfunction. And so you get hypertensive heart disease, heart failure, more prone to stroke, more prone to...
Well, looks like we're having a little bit trouble getting Dr. Hughes-Thompson's signal in. We're going to keep working on that. She has so much valuable information to share with us. Dr. Comfort, in the meantime, I want to go back to the first time you saw Alex as a patient. What did you see that made you think, hey, there's something else going on here?
So there were a couple of things. So first of all, Alex was young. He was probably in his early 30s at the time, and he was on a whole lot of different blood pressure medications. I think probably 6 or so when I first met him. And so that was clue number one, that there's something else going on here that's driving this blood pressure, probably at least contributing to that. The second thing is aldosterone. We can see some subtle changes in the blood work on him. And I actually went back and double checked this since it's been a while since we had done this. And one thing, aldosterone will cause you to retain sodium, and it'll cause you to kind of leak out extra potassium in the urine. And so we'll see that reflected in the blood work. So his sodium level was a little bit on the high side, higher than what we would expect, and his potassium was a little bit on the low side. And so that was another clue that, hey, this is something that we need to chase down a little bit more.
And so you sent him then to
First step
what?
was go down to the lab and get some blood work. So we checked his aldosterone level in the blood.
Okay.
Yeah, and it was elevated there.
And then you went from there.
Yeah, and then we were kind of, from there, you know, sometimes you would kind of look for an adrenal nodule or something like that. In his case, he had already had imaging, so we just kind of reviewed that, and then that kind of sent us down that pathway.
Alex, one of the things that really stuck out to me when we talked was you talked about the feelings you had when you were struggling with your blood pressure, and one of them being, I think you said, I felt like everyone was looking at me thinking it was my fault, because you were doing everything right. And to finally have a diagnosis, what did that feel like pressure-wise and in your mind and your heart to know that you finally had a reason for this?
Well, I think I could eat healthier, I could lose weight, I could do many different things, but to the extent that I had done those things over the years, there had been no improvement in the blood pressure numbers.
Right.
And so it was this kind of stalking horse of, hey, I know this is bad, I'm trying to do the right things, and I'm not seeing a corresponding decrease in the numbers. And so the diagnosis was helpful as much as it clarified that it was kind of something beyond my direct control.
Right.
I mean, it's a reality that, yeah, it's just not something I could directly impact. It required a medical response, and in my case, due to the bilateral nature, that's a pharmaceutical response. I know when we initially discussed it, it was that possibility of it being a singular gland, in which case it could have been a surgical response,
Right.
which would have just kind of increased the general quality of that, would have potentially cut off all of the blood pressure meds. And given the amount of medications I'm taking, that would have been wonderful. But thankfully, there's a team here that we can dial it in with the pharmaceutical approach, and I'm on a better path.
We talked about that team feeling at the end of our story we aired at the top of this program.
Correct, yeah.
Is that seeing all these doctors and researchers and nurses and caregivers?
Absolutely. I mean, Dr. Comfort mentioned the interventional radiology and the work they do, and yeah, I mean, just there's different facets of care that at a smaller institution or in a more rural environment that wouldn't be immediately available.
Do you know anyone else in your family that has hyperaldosteronism?
I don't, no. And I mean, Dr. Comfort can speak to if it's a genetic characteristic, but I'm not familiar with anyone in my family that has it.
That's actually one of our questions that we've got from our viewers coming up. And if you have any questions or comments that you'd like us to share or ask in real time, just send them to us on YouTube, Facebook, the All Things Heart email. All the links on how you can connect with us right now are there on your screen. Let's get to is there a genetic component, Dr. Comfort?
So there is. I mean, well, like most diseases, there's probably some component of genetics that predispose people to this disease. It's not a real clean genetic increase, however, but we can see this, and there are familial cases that have certainly been described. But most of these are sporadic, and that's probably the case with Alex's as well.
Just lucky Alex?
Lucky Alex.
What are the odds that someone has this? Is this a rare condition to have?
You know, like Dr. Shannon was saying, it's more common than we realize. We under-recognize it, and so of people who have hypertension, recent studies are suggesting around 20% of people have elevated aldosterone. So much more common. I think earlier studies were more in the 5 to 10% range, so it's probably somewhere in that vicinity, but much more common. We don't always chase it down though. So a lot of times, we're going to treat them with the first couple lines of blood pressure meds, and if that works, then we don't need to send people through all these other treatment or these testing and things like that. And so that's probably one reason why it's under-recognized.
One of the reasons that we're doing this topic as a program is, Dr. Comfort, you talked to me about this because you're so passionate about the topic of high blood pressure. Generally speaking, across the United States, why are you so passionate about this?
Well, I mean, I think it's one of our biggest public health problems right now. And so half of the country, or half of the adult population in the U.S. has hypertension. And one of the problems is only half of those people who have hypertension know they have it or have been formally diagnosed with that. Gosh. And of those who've been diagnosed, only half of them have their blood pressure controlled. And so as a nationwide health system, we're batting about 25%, which isn't great, and it leads to all these downstream problems, heart disease, stroke, kidney problems, Alzheimer's disease, and it can really increase those rates. And so I think it's a root cause of so many really important things, and that's why I think I'm passionate about it, and I see it every day. I see it every day in my clinical practice, and so it's very kind of near and dear to my heart, so to speak. And
then downstream, specialists are seeing it tied to it. Like Dr. Thompson, what percentage of your patients would you estimate have high blood pressure?
Tell you how many don't. It's part of heart and cardiovascular disease. People who end up with cardiovascular disease, hypertension, or abnormalities in blood pressure are almost always a part of it. It's very rare not to see somebody who has some component of abnormal blood pressure in the cardiology world.
That's what keeps you busy. One of the things that keeps Dr. Thompson busy, patients coming in with high blood pressure and all the other problems associated with it. Dr. Comfort, just to reiterate, it's so surprising to hear this when it comes to the numbers. So I want to break it down again for our audience. Half the people in the U.S. have high blood pressure. Mm-hmm. Of those, only half of those people know they have it. Mm-hmm. And then of those, only half of them have it under control.
Yeah.
What is the disconnect?
Well, I think there's several things. Number one, we call high blood pressure, the silent killer, so to speak, right? Patients generally don't have symptoms of high blood pressure. They don't know they have it. It doesn't worry them. Most people come to see the doctor when there's a problem that they can identify. They're in pain or they're feeling bad or something like that. So it's kind of like a stealth bomber or something, right? It's kind of going along, nobody knows it's there, and then it drops this big bomb on people, in this case in the form of a heart attack, stroke, some major event like that. So I think that's part of it. And I think number two, because it's so common, I think doctors like myself, we can get complacent with this sort of stuff, right? It just becomes routine. We see it all the time, and people, we kind of, it's just like anything else, right? You get almost desensitized to it. Mm-hmm. And so I think we can sometimes become a little bit complacent as providers with that.
It's striking what you said about some people walking around not knowing they have it, because talking to Alex, there were stretches of time where you didn't think there was anything wrong with your blood pressure.
That's right. When I was 19, my dad's health insurance had changed, and I went into the local doctor as a kind of routine follow-up, but it was a different care provider. And when I went in, the nurse took my blood pressure 4 times and left the room quietly. The doctor came in and took my blood pressure once, and he asked if I'd ever been told I had a heart murmur. And he then told me I had blood pressure that was the 210/180. And that was from my understanding, that's a pretty critical point. And so his response was like, we need to admit you to the local hospital because we need to get an understanding of this. It turned out that the heart murmur was it was because the blood pressure was so high. Wow. I was getting some regurgitation in the mitral valve. And then later in the clip you all showed, I had 2 trips to the emergency room. And so in my case, that mitral valve murmur would occasionally present with chest pain. And so, I very distinctly remember hanging out with some friends, like normal video game night, what have you. And I just started saying, like, my chest hurts, like my arm hurts a little bit. Oh my gosh. And one of my buddies was like, dude, you got to go to the ER. Like, that's like classic television style, you're about to have a heart attack.
And how old were you?
At that point, I would have been 20.
Like, no 20-year-old's going to assume they're having a heart attack playing video games.
And
right?
then I went in, and I certainly don't remember what the blood pressure was at the time, but the doctors were saying, this is blood pressure, we need to get it lower. And so the treatment case was straightforward. They gave me medication, I was observed for a while, but I very much relate that if I hadn't gone in for a basically routine follow-up, it could have been years before I would have known what was going on.
Or worse.
Or worse, for sure.
Maybe would he have not had years if he hadn't have gotten that treated?
That's pretty high. Yeah, I mean, when you're young and you can kind of tolerate this stuff a little bit better, the body kind of adapts a little bit better, but certainly over time that's going to cause a lot of stress on the body.
Dr. Thompson, doing research on this, some doctors describe hypertension, high blood pressure as an epidemic in the U.S. Is that how you would categorize it?
I would say it's a cultural issue. What we're doing as far as diet, exercise, stress levels, just we know 70–80%, you've heard this from me before, heart health and cardiovascular events are driven because of how you're taking care of yourself, how you're living your life. And our interventions, when you talk about these various tests, whether it's blood work, pictures, interventions, yeah, they can have an impact, but most of the time that's 20–30%. So the really impact is helping somebody change their self-care and how they're taking care of themselves. And until we start to shift the direction of that, we're not going to see things like blood pressure get better. And if blood pressure if you want to see improvements in overall cardiovascular well-being in our society, it's going to have to be driven by the individuals and the communities themselves.
And then the other percentage, as Dr. Thompson said, are people like Alex, who are doing everything they can, and you still have hyperaldosteronism, this condition. We have a picture we want to show our viewers. It was given to us by you, Dr. Comfort, and it shows, it's on blood pressure control. It shows two lines. What do the orange and black lines represent?
Yeah, so this is just basically a graphical version of what I was suggesting earlier. So the black line is of all comers who have high blood pressure in the country and what percent of them have it controlled. I think one of the things that stands out to me is that over the last 10 years we have not made a lot of progress in this. And then the orange liners, people, if we put them on medications, we get better, but it still is not great. I think it's in the 60-some%. I can't quite read that, but but to me, what stands out is that over a 10-year period, we've made so many medical advances in so many areas, and this is one that we have not been able to move the needle on.
Huh, that's a shame.
Yeah.
Hopefully awareness will help raise the awareness on this. We do have some great viewer questions and comments coming in, so I'd like to start getting to those. And I want to get to one from Sean. Oh, this is nice. Sean writes, Dr. Comfort is my primary care physician. Grateful to have his expertise and care.
Oh, well, thank you, Sean.
There you go. Jean wants to know, is high blood pressure always caused by hyperaldosteronism?
No. Yeah, no. So most cases of high blood pressure are what we would call primary or essential hypertension, and so that is the overwhelming majority of cases are primary. There are secondary causes of high blood pressure. Probably number one is obstructive sleep apnea. So that's one thing that we would test for, and I'm sure we put Alex through that testing.
Were you tested for that?
I was.
Did you have it?
And I do have it.
Oh, wow.
So.
Oh, no.
You're going to have a double whammy
Double
here, right?
whammy.
You know, I think hyperaldosterone is considered the second or third most common of the secondary causes, and so it is a smaller percent overall.
Vera has a question. Vera wants to know, what is the time frame before taking a resting blood pressure? Dr. Thompson, is it 5 to 10 minutes?
Yeah, I usually want to be in a resting state for at least 5 minutes, or, and it varies. So somebody who's 20 years old and pretty good physical fitness, they usually are in a recovery or resting state after they've walked or done something for, just a couple minutes. But as you get older, somebody who's 80, say 90 years old, they walk down the hall and sit down in the clinic and their blood pressure may be pretty elevated, but if you give them about 5 more minutes, it'll come down 20 points on that systolic side. So it's all a little bit relative. We usually use a standard of 5 minutes, but again, you have to put a little bit of an asterisk there because it depends on the individual and the situation.
Angie has a question. Angie wants to know, do doctors regularly test for this when someone struggles with high blood pressure? Dr. Comfort.
So if they have resistant hypertension, so they're on multiple medications and we're having trouble getting it under control, that's usually the trigger for me that we need to go looking a little bit more.
And Dr. Thompson, what about you?
Yeah, again, when they get to me, they're usually already on, that's 3 medicines. One should be a diuretic at good doses. Most people with high blood pressure, it takes at least 2 medicines at good doses, if not 3. But if you're on 3 medicines, being compliant with those things and trying to do a good job with your diet, exercise, sleep, yeah, we do go looking a little bit closer. But a lot of times, again, knowing that we're talking about primary hyperaldosterone, but the predominant elevated aldosterone that is a component of blood pressure, again, that's much higher. And a lot of times I'll already start to treat them when I see them.
Jeremy wants to know, this is a great question, Jeremy, can the imbalance that hyperaldosteronism caused trigger other things elsewhere in the body? Do you see it pairing with kidney or liver issues, Dr. Comfort?
Liver, not so much. Kidney, it can downstream, probably more through its effects on blood pressure and fluid status and those sorts of things.
June has a question. June wants to know, can I request this test for hyperaldosteronism?
You can. It's an easy test to do, but I don't know that it's always necessary. So if you don't have high blood pressure, there's really no reason for us to check that. If you have high blood pressure, you're on 1 or 2 meds and your blood pressure is well controlled, again, probably not a reason for us to go chasing that down.
What was it, Dr. Comfort says it's an easy test to do. What was it like to go through it?
Well, the initial tests are straightforward. Like he's mentioned, it's blood work, it's urinalysis. The more complicated test was the blood sampling.
Threading the needle.
Yeah, threading the needle.
Vein, yeah.
So that was, I mean, as a patient, it was very straightforward. I mean, it was easy, so to speak, because I was along for the ride.
Were you awake and talking?
No, I was not. There was sedation because of how precise the process is. I couldn't move at all, and so I was sedated for it. Yeah, so it was an easy test as much as it was not complicated, but it was complicated to the extent that there was sedation and a procedure, so to speak. But that's the tail end of a longer process.
Right. Jim has a question. Dr. Who's Thompson. Jim wants to know, are there specific foods I can eat every day to lower my blood pressure without medication? If you had to name top 2 foods to eat that could lower your blood pressure, are there any?
Not really. It's more about what you don't eat. So you have to be cautious with carbohydrates, processed foods, things like that. So shop fresh. If you can get something in the fresh area or the frozen area, that's way better than when you go to the shelves. So stay away from the drive-through, stay away from the shelves.
Someone once told me it's better to shop around the periphery of the grocery store, because if you go through the center, you're not going to find
Never heard that.
the best things for you. Is that something that you've heard before as doctors?
I've not heard that, but it does make sense. I'm thinking about my grocery store right now and the layout. So yeah,
the center seems where all the
true. Yeah.
stuff that tastes great is, and the stuff that's not the greatest for you. As we wrap up this discussion, I would love some final thoughts from our guests. Alex, I want to start with you. What would be your message to viewers?
One would be to seek out a primary care provider, meet with them as is a normal schedule, whether that be annually or biannually, depending on your age, and then heed their advice. Adhere to that treatment protocol. If you do have high blood pressure, take the medication. Those changes can be hard to set patterns to, but once you do, that helps the whole process.
Do you have any plans this summer?
Summer's my busy time, so I'll be working and getting things done.
Working at the school, right? That's when the kids aren't there.
That's
so
when they're not there,
done.
so I can paint and clean.
Dr. Comfort, what about you? Not your summer plans, but your final thoughts.
That'd be more fun to talk about. But don't ignore blood pressure. I think we get complacent on it. And I'm just going to leave with a couple of last-minute statistics here that I wanted to touch on earlier. So, hypertension is implicated in 50% of all strokes, 70% of hemorrhagic strokes, 25% of cardiovascular disease, but 50% of cardiovascular disease death, 15 to 20% of Alzheimer's, 28% of chronic kidney disease. So this has broad effects all over the body, and a lot of these are kind of downstream. So don't ignore your blood pressure.
Dr. Who's Thompson?
Yeah. So high blood pressure is at the core of your health. It's telling you how your body's running. And it's critical to take care of it. A lot of the things how you take care of yourself matter. And it's not random. When your blood pressure is elevated low, there's something driving it. There's reasons it's the number it is. And we absolutely have to look into that and make a difference, because the impact is unmeasurable.
Dr. Who's Thompson, thank you for joining us. Dr. Comfort, thank you for taking time out of your day, seeing patients to come see us. And Alex, thank you for sharing your journey. We're really glad that you're doing okay, and it's going to help a lot of people to raise awareness.
Wonderful. Thank you.
And thank you so much for being with us today. As viewers, if you would like to watch or share any one of our previous episodes, just scan the QR code on your screen right now. It will take you to links of all of our past episodes. And coming up next week on All Things Heart, this former Kansas City Chiefs player is used to battles on the field. His new opponent is inside his body. His favorite teammate works right here at the University of Kansas Health System. That's next Thursday at 8 a.m.
Coming up tomorrow on the Morning Medical Update, Ginny Curtin has a photographer's eye, and she's using it to help the team that saved her life. I'm Jessica Lovell on the next Morning Medical Update, the special perspective of a cancer survivor, the treatment that's keeping her traveling the globe and bringing back art. Friday at 8.